which will be taking place on August 1st in coordination with VGM, is putting a competitive bid, little reimbursement show together. There's information on the slide there and also on our camp's website for registering for that. And also on September 5th is our annual camps convention, which is held in Long Beach, and there's information on the camp's website for that as well. So moving on to the next slide, please. Just to briefly go over today's agenda, Bob Ackerman, our camp's executive director, will talk about the Cures Act. Paul Andrusik with VGM will talk about our grassroots efforts. Then we'll go back to Bob to talk about the legislative work through the subcommittees. Paul will talk about the new rates and what those will look like, and he'll also work with Craig to go over some numbers in the calculator. And then Craig Douglas will go over kind of what these changes mean for managed care. And then at the end, we'll do some Q&A. So having said all that, thanks again for joining the call. I'll turn it over to Bob Ackerman, the camp's executive director.
Good morning, everybody. If you can go ahead and take the next slide. Go ahead and start. So give you a little bit of background as to why we're here, what's going on, what's happened, and you know, little glimpse of the future. So the 21st Century Cures Act was signed into law by then President Obama in 2016, had bipartisan support. The act prohibits federal financial participation payments to states for certain DME that exceed what Medicare would have paid for the items on a fee schedule basis or under competitive bidding. And that provision actually took effect on January 1st, 2018. So in essence, all Medicaid programs, including Medi-Cal, were informed that if you exceed in the fee-for-service program that you maintain, if you exceed the applicable Medicare competitive bid rates, the federal matching funds that the federal government provides to the Medicaid program in California, that's 50%. So 50% of every Medi-Cal dollar is federal. If you exceed that total in the aggregate, you are at risk for having part of that money taken back. So all Medicaid programs as of 1/1/18 have to be sure that they are not spending in the fee-for-service program in an aggregate basis more than they would have paid under the Medicare rates. So obviously competitive bidding then impacts Medi-Cal fee-for-service rates. Medi-Cal has, for the last decade and longer, has had a statute in effect that says for DME, Medi-Cal pays 80% of the Medicare rate for most DME and 100% of the Medicare rate for custom rehab equipment. That has always been the law, as I said, for over a decade. So as a result of this Cures Act, California submitted what they call a state plan amendment, and that's basically an amendment to their Medi-Cal Medicaid program in California that's on file with CMS. When they change rates, when they change coverage, they're required to file a SPA with CMS. They filed that SPA in January, and it said that they will reimburse no more than 80% of the Medicare non-rural rate for most DME effective 1/1/19, January 1st, 2019. So that means that the rates that are currently being paid are going to be lowered in the case of most standard DME to 80% of the Medicare competitive bid rate effective 1/1/19. That SPA is submitted, but not yet approved. When it is approved, that should be sometime in the near future, probably the fall, then they would retroactively apply those new rates to 1/1/19, meaning that new rates kick in. We'll talk about those rates in great detail. And by the way, we're going to go back to 1/1/19 and recoup any overpayments based upon those new lower rates. Next slide, please. So the rate reductions apply to certain DME items. Those are competitive bid items. There's about 256 items that are covered under competitive bidding. They're mostly E-series codes, and some A codes include the most common DME items: canes, crutches, hospital beds, oxygen concentrators, wheelchairs. Does not apply to medical supplies, O&P products, and does not apply to items for which Medi-Cal is not the primary payer. Again, they will pay 80% of the non-rural competitive bid rates effective 1/1/19. In addition to that, the existing 10% provider rate cut is still in effect, so the rates really are 70% of the Medicare rate, the non-rural rate. When you look at those rates, as we'll see later on, a big discrepancy between rural and non-rural. This is the non-rural rate or urban rate. Next slide, please. So what have we done about that? We talked to the department back in December of 2018. We submitted a letter of opposition to the SPA request on January 19th, 2019, basically indicating that these rate cuts are not sustainable. You're not going to have any providers to dispense this equipment. It's totally unfair, etc. We worked with Home Care, VGM, and others to try to mitigate these cuts, but the SPA was submitted. So we determined very quickly that the best avenue for relief was through the legislative budget process, which was beginning with the governor's budget proposal in January, then goes to the subcommittee process, which we'll talk about, results in a final budget being adopted by June 15th. We needed to change the statute that governs DME reimbursement. We had to do it in a very short amount of time. We had about 60 days to get out our arguments to the key budget subcommittee members and try to get it included in the state budget for 2019-2020. Next slide, please. So I'll turn it over to Paul, talk about the grassroots effort that we undertook.
Great. Thanks, Bob. Appreciate you kind of handing that over. Can everybody hear me on there? Bob, can you hear me on your end?
Yes, I can.
Great. So I appreciate everyone jumping on today. As part of the CAMPS education and part of the CAMPS Medi-Cal Task Force, you know, this was brought to attention at one of our board meetings. We kind of got together, actually started understanding what this was all going to mean to the state of California, and understand we need to take steps very quickly. One of the first things that we were doing was basically grabbing everyone together, try and educate as many DMEs as possible in the state of California. So with grabbing the folks from Home Care, grabbing the folks from VGM, grabbing all the board members that are part of CAMPS, we sent out a number of different emails, starting with VGM, CAMPS, Home Care. Let's do a call to action. Let's get people out there. Let them understand what's going on. We wanted to get a group of people together that could really help attack this problem. So on our first call, it was basically, hey, let's educate people, understand what's going on out there. We had about 115 attendees. Thought it was a great turnout. Was very excited about that. Our biggest problem was at the end of that call, we went from basically was, okay, you guys now understand what's going on. We kind of need to take the next steps, you know, following up with legislators, following up with senators, assembly members of the like. On the next call, we went to about 15 people. And that number did grow and went up and down kind of as we did that. So we were basically having weekly calls, setting up direction on what subcommittee members we need to reach out to, what assembly members, who are the key ones, you know, working with VGM, working with Home Care. One of their biggest things was, let's find a champion on our side that's really going to help push this forward. So we grabbed, you know, a couple of the key legislators there up in Sacramento and really focused on them. And I really got to give the folks, Terry Rocchiato did an amazing job with her team and just really understanding the process up there, having gone through it several times. And John Cassar, what he did with his team, he really basically pulled his entire sales team together and all had them making calls, all had them pushing out. And we had a number of other companies out there. I know SG helped quite a bit. Owens helped quite a bit. You know, a number of other different companies that, you know, worked in and out of this. So really appreciate all the work they did. So besides just doing that, we were working with Bob, and Bob will get a little bit more into this on the legislative side, but going out and working with the different groups, working with the CCSs of the world, working with the different programs there, because this is really who it's going to affect, in those hospitals and the children and those different patients. So we were going out there, grabbing those different people. So every week we were making different calls, assigning different people to make calls, going out and going. So it was about 2.5 to 3 months that we were making calls to different legislators. It went very well to the subcommittee. We felt we were able to educate them, had a lot of time Not that 2.5 to 3 months is a lot of time, but it was time to educate them. So we were able to move that forward. At the same time, from Bob's instruction, we went and got a PR group, Perry Communications, that was paid for by different funds raised through camps. So VGM, you had Terry Rocchiato paid quite a bit. You had John Cassar, once again, and his group at Supercare. You had a number of other different DMEs that helped raise those funds to help get those messages out. So we were pushing that through and trying to get to the different industry rags and get the word out that this is not going to be something that's feasible. So next slide. And so I'm going to pass this back over to Bob and kind of take the legislative, and he's going to go into a lot more on kind of the different groups that we were able to work with there and go through that. So I'll let him kind of take over.
Thanks, Paul. So the process is basically this, is that the governor puts out his proposed budget and the legislature develops their version of their own budget. And each House, the Assembly, and Senate has a budget subcommittee that focuses on health and Medi-Cal issues. So we were focused on those two budget subcommittees that deal with Medi-Cal. As Paul said, I think we did a great job enlisting support of people other than us as providers, getting other people to make the case for us. California Children's Hospital Association, California Hospital Association, Children's Specialty Care Coalition, which are the CCS physicians, all very supportive, worked the building with them, met with members talking about the impact of these cuts on their ability to timely discharge patients and quality of care. We've talked about a study that was done at CCS last year that showed that patients were waiting a long time to get equipment. They were having a hard time finding providers. There were less providers out there. They were more selective about the equipment they were doing, and it was impacting the ability of these people to discharge patients in a timely manner. So they were telling the story for us, very effective. And one thing I wanted to emphasize here, the reason why this federal directive on not exceeding the Medicare competitive bidding is so important, California has not kept pace with the changes in Medicare. So the Medi-Cal fee schedule at 80% for most DME is based upon the January 1st, 2016 Medicare competitive bid rates. So as a result, the rates you're currently being paid are higher than they probably should be if they were tracking Medicare competitive bid rates all the way through 2018. So that's why this is so important, and the reductions are going to be so dramatic. So we developed a background paper, we developed examples through SuperCare's folks, really very helpful to provide a graphic demonstration of before and after. What are the rates now? What are they going to be? What's the clawback going to look like? Very dramatic impact. We asked for a fix to both the budget subcommittees, basically first repeal the 10% provider rate cut. Second, move the Medi-Cal rates to DME to 100% of Medicare and use a blended rate of non-rural and rural. That blended rate would be much higher than the non-rural rate. They obviously can't exceed 100% of Medicare, so we can't ask for anything more than that. So we tried to max that out. We also pushed the envelope a bit on the non-rural versus rural. We may have had a problem with that, but we thought that was the most equitable thing to do because the rural rates, no one ever bid those rates in those rural areas, yet they're being impacted by them. We also required Medi-Cal to recognize and pay for rehab equipment using the KU modifier. Medicare recognizes a higher level of reimbursement for certain wheelchair bases. Medi-Cal has not been using that, even though they say they do. They're not using the KU modifier, not recognizing it. We ask that they raise those rehab rates as well. So next slide, please. So this, I'll let Craig and Paul take over here, but I think we're, sorry, I thought there was a slide. Yeah, so let me tell you what the outcome of all this was. So the two budget committees adopt their version of the budget, send it to what they call a joint legislative budget conference committee made up of 3 members from each house. In this case, it was 5 this year from each house. They then craft a final budget that they send to the governor. So we were successful in getting the DME fix I outlined into the Assembly budget subcommittee and into the Assembly version of the budget. That went to conference committee. It is there that these issues are resolved. We pushed for the Budget Conference Committee to adopt our version of this language and get it into the final budget. Ultimately, we were not successful. The administration continues to believe that there will be no impact on access. In the SPA that I referenced earlier on that they submitted to CMS, they said their access study said we have 1,000 enrolled providers for DME in the program. If only 50% stay at these rates, we'll still have enough providers, and that's the extent of their access study. We testified in committee. I don't know how you determine access when you don't tell people what the rates are going to be, and no one is actually providing service at those rates. So I think it's a fallacy for them to continue to take this position, but that is what the administration does. They refuse to make adjustments in rates until access is demonstrated to be impaired and there's impact on their patient base. So at the end of the day, the budget that went to the governor that was signed did not include any relief for us. So next slide now.
And I'm going to jump in for 1 second before Craig there. One of the biggest things we really ran into there on both the legislative and the grassroots side was, as I said before, we had about 2.5 to 3 months on the subcommittee side of, getting a chance to educate these people, getting in front of them, getting to really get to know them a little bit and help them understand our position and where we're at. One of the biggest problems we ran into is we went to the full committee is that we were basically given 2 weeks. And they switched out everyone that was on these subcommittees with brand new people. So basically our 2.5 months that we were educating people went right out the door. And at the end of that 2 weeks, they ran out of time as well. So basically on a Saturday and Sunday, Bob could probably tell you how many different issues they basically did an up-down vote, which was very quick and very uneducated in my opinion. But did a very quick up and down vote on a Saturday and a Sunday to actually, when they were finished passing things. So at that, I'll kind of pass it back off to Craig and Bob.
Yeah, a little quick at the end. Yeah. Thank you, Paul.
All right, this is Craig. Can you guys hear me out there?
Yes.
Yes.
Thank you. All right, so this slide, for those of you that have been listening to what Bob and Paul and Dave started out talking about, you start hearing about percentages and okay, there's a 20%, 80% and a 10%, and yeah, maybe I can live with that. This slide gives you the actual numbers. And if you can look at this and feel like, oh, that's no big deal, I think I want to come work for, or actually I don't want to come work for you, because I think this paints a very, very grim picture. This shows what the rates were and what they will become if this all goes through as it's been proposed. So right now, for Medi-Cal patients, that top line, E1390, that's an oxygen concentrator. You're being reimbursed $144 a month, $144.74. Maybe less than 10% clawback. So at worst, you're getting $130 a month on oxygen concentrators from Medi-Cal. If this goes through, the current Medicare non-rural rate is $65.70. The proposal is that you would be reimbursed 80% of that non-rural Medicare rate, which brings it down to the $47.30. So you're basically losing $100 or 67% of your reimbursement on that code alone. And as you go down through there, you've got the portable oxygen concentrator, the portable oxygen system in EO431, CPAP EO601, the humidifier for that, E0562, the BiPAP, the nebulizer, the wheelchair, the walker, and the hospital bed. You'll see that virtually every product, you're at least 50% below your current reimbursement. 50% is the best case scenario on the spreadsheet, and that's for that E0431 portable, so your cart and regulator or shoulder bag, your portable gaseous oxygen system. The K1 is going from 4730 down to, it says 1572. I don't think that's accurate for that particular code. If anybody wants to correct me there, please do. The Medicare non-rural rate, the 2183, is accurate, but that code, because it's a wheelchair, wheelchairs were carved out they're not reimbursed at 80% of non-rural Medicare, they're reimbursed at 100% of non-rural Medicare. So if the non-rural Medicare rate is $21.83, that would be the new Medi-Cal fee schedule rate, and it would still be subject to a 10% clawback if that's not taken away. So you'd take $2.18 out of that $21.83, leaves you about $19.80 or something like that, instead of the $15.72 that's shown there. Does anybody on the phone want to dispute what I just said? I believe that is an accurate representation of how that code would be reimbursed. So instead of the $15.72, you'd be up more in the $19 to $20 range. Still quite a drastic cut, well over 50% of the reimbursement cut out of that code. The next couple of slides will show that those same numbers in a slightly different format. So you can see on these the same codes. Old reimbursement is the red bar, new reimbursement is the blue bar. You can see graphically how drastic those reductions are. And Paul has we can click through these slides. Again, it's the same codes that were represented in that first graph, just a slightly different way of presenting that. Does that last slide go one more? You've got EO277 represented on there. That's really not an apples to apples comparison. I believe that Medi-Cal reimburses that on a, if I'm not mistaken, on a daily basis, and Medicare has a monthly reimbursement rate on that product. So it didn't work to have those side by side because it was not an apples to apples comparison. So you only see
correct.
the blue.
It's daily. Yep.
Yep. So we wouldn't want to put a daily rate of $19 or something up against a Medicare reimbursement of $121. It just that's not an accurate portrayal. So we can leave that one alone. The other thing, Paul has a calculator that goes into some of the financial impact on your business once you start entering quantities, how much of these items you are providing on a daily, weekly, monthly, yearly basis that can help show you some of that impact. So I think that's it for the slides that I was going to cover. I'll turn it over to Paul to talk about the calculator that he developed a little bit. I think maybe there's some contact info on the next slide.
I don't know if it's Shelby or Emily who's driving there. If you guys can pull up the calculator for me, please. And we're going to go over this kind of briefly. We're going to mainly stay in that 1390, if you can go all the way to the bottom and to the far left. Yeah, let's go with the 1390. So we're going to play here in the oxygen concentrator area. And this is going to be available for you guys to download, take a look at. It's really, let's take a look at how this is going to affect your business, what this is going to mean for your business, what's moving forward, what's tomorrow going to look like. So at the top there, you have the code, and you have all the different codes there at the bottom. So basically straight on through. And I did a lot of the main codes that are out there. So you have the current rate, which is in there at the 144.74. And then you have below that the expected rate. And then you have January through September. I only did through September because that's roughly when we're kind of expecting that SPA to start taking effect. And I'll tell you why I kind of stopped there here in a minute. So under January, you can change, this is supposed to be number of patients. So if you want to change that, say, to 105, whoever's driving that can make that a 105 and be right under January. And go ahead and hit enter. You can see it will change the numbers down below. So your current rate payment is going to be that 15, basically 15,200. And below your expected rate is going to go to a whopping about 5,000. So a pretty dramatic cut. So you're looking about a $10,000 difference in about 100 patients in 1 month. And then you can play with those numbers all the way across. That difference at the bottom is, I can't say it's going to be exactly what the clawback is going to be, but it's what it definitely can be, because that's going back to January 1. That is what they're going to be changing the rate to. So that's what you guys have to be aware of. So I made this calculator basically so you can go back, you can download this, you can reach out to myself, you can reach out to Dave, you can reach out to Bob. They're all going to have a copy of this. So you're able to take this and kind of play with it as you want, put your own numbers in, how many patients you currently have. And if you look at the 1392, you know, it's just basically the same thing. So you're able to go in there and make those changes. And you can look at the far left, you have the totals versus the total difference. And that could be, at that point, your total callback, what they ask for these different codes. So like I said, this is not a guarantee what's going to be, but it's kind of what the best estimate is right now. So it basically puts the tool in your hands to kind of estimate kind of what you guys want to be doing and how you guys want to be looking at your business as we go forward. So if you want to kind of jump back into the slides there, and we'll have questions afterwards, and we can jump back if we need to. So if you want to go to the next slide. So I'm going to give this back to Craig to, he's going to go over speculations on managed care, kind of ripple effects. Craig is really our expert on both the Cures Act and managed cares at VGM. And if you were on the competitive bid webinar earlier, he knows his calculator, so he actually helped validate mine. So I'll take it back to Craig.
Thanks, Paul. So as you saw what Paul's calculator showed, their potential clawback for a provider who provides to roughly 100 oxygen patients a month, you're looking at a potential recoupment request from Medi-Cal for $91,000 just on the E1390 code. You get a bill in the mail today for $91,000 with an expected check to be written. I think a lot of you would have trouble coming up with that to write that check. These are very, very drastic changes to reimbursement if this goes through as planned. So on top of that, in addition to what Medi-Cal may do, you also have to look at what some of the other managed care organizations that play within Medi-Cal might do as well, or how these changes might impact your reimbursement from those managed care MCOs. If they see this happening, it's very likely that they could say, well, we're going to do something similar. And even if they don't do anything at all, they don't make any changes at all, if your contract with those managed care organizations is worded or structured such that your reimbursement is just some X percent of current Medi-Cal fee schedule. If Medi-Cal fee schedule changes as much as this is proposing it to change, from a Medicare standpoint, you're no longer at 80% of Medicare, where you were at maybe 200 or 220% of current Medicare with the old Medi-Cal fee schedule. Now you're at, for straight Medi-Cal, you're at 80% of Medicare, but for these managed care organizations, if your contract is worded to where it says that your reimbursement as a provider is 80% of Medi-Cal fee schedule, Medi-Cal fee schedule becomes 80% of Medicare. 80% of that 80% is now 64%. When you factor in the 10% clawback, if that remains, you're now at 57% of current Medicare. If your contract were at 90% of Medi-Cal fee schedule with those MCOs, that becomes more like 65% of current year Medicare. Providers have been running away from Medicare business because of the rates that exist at 100% of Medicare. The competitive bidding program has really done a number on the Medicare reimbursements, the Medicare fee schedules that are in place. Providers can't make it work at 100% of Medicare. I think you're going to have a real hard time doing it at 57 or 65% of that same number. This is a big deal. You all need to be very cognizant of what is happening and how it could impact your business, and make sure you're trying to do something about it. Bob alluded earlier to the fact that they've said, well, we have 1,000 providers, and if 50% of those leave, we still have 500. We still think that's plenty. You had 1,000 providers. Medi-Cal had 1,000 providers at the old fee schedule where reimbursement on oxygen was $144 a month. You lower that to $44 or $39 or whatever it is. I don't think 50% of your providers are going to stick around. I don't know how they could make that work. Medi-Cal needs to know that the provider network will not in any way, shape, or form look like what it does today if these changes do go through. With that, I'll turn it back over to whoever is going to cover. I think, Paul, this is you.
This actually goes over to Bob for the call to action.
Yeah, so we've been talking about this for a while. If you're a CAMPS member, you've seen material from us. You've been on the website. You can visit our website, camps1.org. You have information about the cuts, what we've done, copies of letters. We've been working, obviously not successful, but it's not through a lack of effort. So when you talk to your legislator, there's a website there, a link that you can find your Assembly and Senate member. You need to let them know what's going on. I think, we'll continue the outreach. We'll continue to work. We're working with, our companion organizations, the hospitals who are already seeing that. The CHA representative told me that their hospitals can't find anybody to do a walker in San Diego. People are just being, selective about what they do, and certain items they'll continue, certain items they won't. It's definitely having an impact, and people need to know what's going on and what the reality of these reductions are going to be. If you have questions, you can reach out to any CAMPS board member or myself and talk about it, but the ball is really in your court now, because unless we're successful in getting the SPA not to be approved, which I think is a long shot, but we're going to try and do that as well. These rates are going to hit. We don't know exactly when. It's a matter of SPA approval, when the department gets notified, when they actually notify providers. But the SPA says clearly they will go back and utilize these rates to 1/1/19. So whatever you're getting paid now is not what you're going to be able to keep. And you need to bear that in mind when you're making decisions as to what services you provide, because these rate cuts are dramatic.
And Bob,
Next
there's
slide.
a number of things that are people that are trying to get that SPA from stop being approved. What are some of the things that are going on there? I know that Terry's group is. Go ahead.
Yeah, we're going to submit a letter to Region 9. CMS is cut up into regions. For California, Region 9 in San Francisco has oversight. They apparently are the ones that are looking at this. Unfortunately, there have been other states that have adjusted their rates. The statute, is right now 80% of Medicare. CMS has told the states to do this. So it's a matter of whether or not they see that there's going to be a problem with these rates. As I said earlier, the directive is that that the state Medicaid program can't pay more in the aggregate for fee-for-service rates. 80% of the patients in California are on Medi-Cal managed care plans. So that's not part of the calculation. But as Paul pointed out, Medi-Cal managed care plans can pay what they want. They're not obligated to pay Medi-Cal rates. They could theoretically pay more. They can pay less, as some of them do. But the department doesn't tell them what they have to do. So that's the big kicker here, is what will these plans do when these rates go public? Based on our experience, most plans gravitate to the lowest rate they can find. If the Medi-Cal publishes these on their website in September or October, at some point the plans are going to pick up on these and probably adjust their rates accordingly. So there's the double whammy there. You can't think that you're in managed care and you're not going to be impacted by this. You are.
Okay, I'll let Dave kind of finish it up there, and then just kind of make some closing remarks, and then we'll open it up for questions.
Sure. This slide here, we wanted to provide contact information for myself, Bob, Paul, and Craig. We've already fielded some questions about slides related to today's presentation. and we will push out the slides either through email or make them available on the camp's website. But if you want to call or email any one of us, our contact information is provided here. Next slide, please. So at this point, we've given all of the updates. If the operator could please open up the line, we'd like to open up the call to questions.
And we are also recording this, so we can actually send you out the recording if you want to listen to this back as well. And it'll actually have the slides as it goes through the recording.
Well, I'm paying $25.
Whoever is running the presentation back in Iowa, were there any questions in the queue first?
Hey, Paul, it's Shelby. We haven't gotten any questions that have come through in the chat functions, and we did unmute the lines for everybody else. You have about 80 people on, so.
Okay, great. So any questions out there, please go ahead.
Yeah.
Doing Q&A now.
Yeah. We got to, first, we got a medical patient. And then we need, to contact some of
Is anybody else having a really hard time hearing that question?
Yeah, I thought it was a question, but I'm not sure that it was. I think somebody's just talking close to their phone. Just a reminder for everybody that's on this call, if you are talking and you have not muted your phone, everybody can hear you. I don't believe that was a question that was being asked, but if someone does have a question, please feel free to ask that. Just do it one at a time if we can.
Yeah, what's that, Orville? The last four is the one, the number. 324, the 0060 number.
Yeah, I don't think that's a question for us.
Nope. Anybody with questions?
More. They would have to allow us to go back.
Is there an order in which people ask here?
Any order, just jump on in.
Okay,
Diana,
this is Diana Guth from Home Respiratory Care. If we are Medi-Cal providers, do we have an obligation to take any and all requests, orders?
Yeah.
No, you don't. This is Bob Ackerman. I mean, you could decide to take certain patients for certain equipment and not others. You're not. But once you accept them as a Medi-Cal patient, you're bound by the Medi-Cal rules.
Okay, so but if they're not already one of our patients, we don't have to, right?
Correct.
Paul, there have been a couple of questions that have come in through the chat function. The first one is, will they claw back the 20% coinsurance also?
Right.
And I'll leave that to somebody who's a little more familiar. I didn't realize that there was a 20% coinsurance. Is that just applicable to certain product types, or is that for all Medi-Cal? Is there that much coinsurance on that?
That's for Medis.
yeah.
So these rates apply where Medi-Cal is the primary payer, not a secondary payer.
Yeah. This is what you pay for, right?
Okay, I think that answered that one. So what's the next one, Craig?
All right, the next one is, how fast can we get the presentation copy? I would think that will be ready later today or tomorrow at the latest. Next question is this going to change and forgive me if I mispronounce this, the Charpentier Act?
Yeah, the Charpentier was a legal decision, probably 8 or 10 years ago, affecting wheelchairs, where they required, federal court required the state to pay the higher level of reimbursement that Medi-Cal was paying, rather than looking to the lower the Medicare rate for certain chairs. I think that was narrowly applied to custom rehab equipment, and wouldn't impact the broader array of DME that we're talking about.
Okay.
That's a good question. That's the best I can do.
Okay, that's fair. That's better than I would have done. So thank you for that, Bob. The next question that came through in the chat function, how will this affect codes for which Medi-Cal pays as a purchase, but Medicare only pays as rental? For example, how will the KO823 purchase rate be impacted? Again, I'll default to somebody who understands how Medi-Cal, if they're adopting the Medicare fee schedule, which is only a rental rate for that code, how will they calculate their new purchase price for that product that they had a purchase price published for previously? I think is the gist of that question.
Yeah. Unless somebody else has an answer, I think that's probably one we need to research. I would theoretically think that at some point they would look at their purchase price compared to the rental rate and adjust the purchase price downward. The rental rate has gone down dramatically. Yeah. So I'm not sure how long that would take or whether they would do that and when they would do it, but I think that's probably what would happen at some point.
Have they considered doing a survey to ask the providers if they will continue to participate with these unworkable fee schedule?
Have they considered it?
Yeah.
I don't know. I mean, when we testified in the budget subcommittees, they were right there next to us and had access to the information. And the chairs asked that direct question: how can you evaluate access when you haven't told the providers what the rates are? So logical, Diana, but at this point, the department, as they tend to be with all provider rate issues, until there's blood in the streets, they pretty much say we've got providers, so therefore there's no problem.
So they'd rather see what happens, and which will probably be a disaster, and then try to hustle.
Okay.
And Diana, you could certainly be proactive if you choose and say, we're aware of what has been proposed, and I, as a provider, having seen what has been proposed, I know that if those changes do go through as they've been proposed, I, for one, cannot do that. Here's my notice of that, more or less. So you could certainly let them know where you stand before any of that happens. But yeah, I don't see them doing an actual poll of the provider community.
And, I think John Cassar is on this line somewhere at some point, but I know that he's gotten a survey on the pharmacy side where the pharmacy group has done that. And I think that's, something we've looked at doing or considering doing, but basically we wanted to get this out, get the education out, because truthfully, Medi-Cal has done nothing to educate the population. This is, if you weren't on the call originally, 3-4 months ago, this is probably the first time a lot of people are hearing about this. So, and if John wants to talk to that at all, if he's on the call somewhere.
I have a question. My name is Pablo from CPAP Services. You mentioned that MCOs may also apply. I kind of understood that you said that they would have the liberty to do it or not do it, and they likely would. Would they also apply the clawback and go back and charge the refund as well? Would they be able to do that as well?
You can't be absolutely certain, but in most cases they have not gone retroactive on rates. So I would think they wouldn't do that, but I can't be absolute in that opinion. They just typically have not seen the cost effectiveness or value in going backwards. They just simply adjust rates moving prospectively forward.
Okay. All right.
This is Craig. I would agree with that, Bob. The only thing, I don't think there's been any talk of the state going back to those MCOs and recouping anything from them. I think if that were to happen, it would be likely they would try to do something with the provider group, but Bob's absolutely right. That is not typically their MO. I think they would just do it. If they were to change anything, it would be prospectively, not retroactively.
Mm-hmm. Okay, thank you.
All right, any other questions? Looks like maybe another one came in through the chat feature. So when can suppliers expect these new rates will be implemented if approved?
So the process is, if CMS approves the SPA, they notify the state of California that the SPA is approved, and then at some point, the department announces to the provider community that the rates have been changed. That typically requires notice to, Conduent, who's the current fiscal intermediary for Medi-Cal. That's going to change this fall as well, so it might be part of the transition. They would implement those new rates in the fee schedule in their claims processing system, and then you would see those rates. So the timing for all that is, pretty much guesswork. It typically takes, the state, when they make these kinds of changes in rates, several months to do it. So it all is, a ladder going forward. If the SPA hypothetically is approved in September, I would expect you'd see these rates by December or January, but, they could move faster. But that's kind of been, typical timelines for these kinds of things. If the SPA is approved faster than that, you move that timeline up. So, right now they've had the SPA for several months, and we're waiting for CMS to take action, or not take action.
Yep. Very good. Next question. Since Medicare only rents equipment, does that mean Medi-Cal will only rent and not purchase from now on? I would say that's more of a policy-driven question. There's no mandate that they follow Medicare from a rental versus purchase. They can decide what they want to purchase outright still. Certainly, if they were to adopt and follow exactly how Medicare does it, it would be easier to compare, but I don't believe there's any mandate that they do that they now only rent items that Medicare rents. I think they could still make a decision to purchase things that they want to purchase outright and rent the other things that they want to rent. Does anybody have anything to add to that?
Around, not making any money.
Bob, I think that's accurate. I mean, they've adopted some of the Medicare rules, not all of them, so they can set their own policy.
All right, yeah, we fucked up. But it's like.
What else can we do other than contacting the legislators, or what else can we do as community or as the industry to help with this?
They put in.
I think those are the major things. You should talk to your referral sources about what's coming. Talk to your patients. If you're not a campus member, you should be one, and start looking at the impact of these rates on what you do and how you do it, and make appropriate business decisions as a result of that. Again, I think
so there's
that
nothing we can do to help prevent this from happening. It is actually going to happen.
You got to go through in your.
Well, I mean, we're at this point, the SPA is under consideration. We've submitted comments in opposition. We're going to do more, and hopefully get CMS to recognize the impact of what will happen once they approve that. And if we're lucky, they don't approve it. But other than that, we're back in the budget cycle for next year. And, we don't want to do it after the fact, but at this point, the department is ignoring our concerns.
Mm-hmm.
And that may be partly because Medi-Cal hasn't really heard from many providers about what this will do to them or how it will impact their decision to participate in the program going forward. So certainly you could let them know how you feel about that as well.
Right. Yeah. Exactly. That was the question. So how do we do that? Like, what avenues can we use to communicate that?
I think the big thing is, as Bob alluded to earlier, it's a lot of they have never seen hurt. They've never faced hurt. They've never really heard from anyone but kind of a little bit of the DME community, and only a small part of the DME community. It's been a small number of people kind of trying to lift this ship here. So it's really, making your calls, educating your referral system, letting them know what's going on, letting them know that they're going to have a problem discharging their patients. that they're going to be stuck in the hospital, that they're going to be, you know, it's going to be shifting over to Part A, which is a huge problem for them. So they need to be hearing it from other communities besides just us. Because to them, we are, well, of course we want more money. We're greedy DME people. That's, in their mind, that's what they see. And, you know, we've always gone to say, hey, these rates are going to kill us. You know, we're not going to be able to do it. And you know what? We found a way to do it. We've always been able to make a way to do it. Well, these rate cuts are dramatic to the point it is extremely detrimental. So everyone has to kind of make that decision on their own. I can't tell people what to do. It's a business decision you have to make. But it is getting out there, letting your referral sources know, making your calls, letting your patients know this is what's coming down the line. So you have to do that education as well. And if you have any questions about how to have those conversations, myself, Bob, Dave, other members of the board, you know, Terry Racchiato down in San Diego, John Cassar, Paula Dahl at Supercare, all great sources to talk to, and they'd love to chat with you about how to have these conversations, who to reach out to, who to touch. And, you know, we're here for you. VGM is here for you. AA Home Care, you know, they're more federal, but they also know what's going on as well. This is something that's popping up more and more across the country. I know Idaho just had it popped up, and they weren't even given the chance to fight. They're saying basically July 1, these rates are in effect, and they were told 2 weeks ago, kind of thing. So, but yes, so it's something people are becoming more and more aware of across the country. So, but yes, education of referral sources, patients, alike. So I hope that answers the best I can do kind of right now.
Oh yeah, definitely. Thank you.
All right, the next question on here, can we continue to accept Medi-Cal only as a secondary?
I would think so. Other people may be more knowledgeable than I am.
All right, I would agree with that. I don't have anything to offer there. How will this affect Medi non-invasive ventilators, E0466?
That's not a competitive bid item, so those rates are already 80% of the Medicare rate. They would have benefited, vent patients and vent providers would have benefited from our effort to get that raised to 100% of Medicare, but that's not a competitive bid item. It is up for adoption as a competitive bid item, I believe, in 2021, and there's a big pushback from us and everybody else on that. If it were to become a competitive bid item, we'd probably see much of the same kind of, low ball bidding. So right now, no major change there.
All right, did you say the proposed new rates will not be recouped from the MCOs? Yes, it's unlikely anyway, that we have no definitive guarantee that they won't do something like that, but there's no mandate that they follow suit and recoup anything historically.
Right. DME is 1% of the total healthcare costs. I can't imagine it's worthwhile for the department to go back and adjust the cap rate.
All right, a couple more questions. Medi-Cal as a secondary pays only what Medicare pays, so it pays nothing in most cases. Will that change? Can they recoup 10 or 20% of nothing, is the question.
I've got one in my car.
I don't think it's gotten that bad.
Tire pressure check. Well then.
The last question that's on here right now, how do you recommend we engage our patients in this effort? Should we notify them that if these rates go through, they'll need to find another supplier, and so should encourage their Congress members to act? So Congress members, I don't know.
Yeah, assembly members and senators in California. So yeah, I think you got to educate your referral sources, let them know what this is going to cause and the impact on you. We'll put on our website. There's a Medi-Cal hotline that patients can call when they have problems. Getting patients to start, making those phone calls will be important too. So yes, you should let your patients know what the impact is going to be.
I know, I'm still in the
I
same
think that is all the
situation
questions that have
I've
been posed. If
before.
somebody else has a question that has not been answered, please resubmit it. It may have gotten pushed too far up the screen for me to see it at this point. So if you have a question that has not been answered yet, please retype that. Otherwise, I believe that's all for the questions that have been submitted through the chat feature.
Once again, you can email myself, Bob, Dave, or Craig any questions that you do have, and we'll be happy to get them out to any and everybody. The recording should be available either this afternoon or early tomorrow, just because it's definitely a different time zone there in Iowa. And we'll have these slides available as well. Dave, Bob, and myself have those available now if you want them.
One more question did come in. It says, if this state plan amendment goes through, when would be our next opportunity to request elimination of the 10% reduction, since keeping that in place reduces payments to 90 and 70% of Medicare, which is not required in order for Medi-Cal to receive matching from federal?
Right. So barring the department making that decision on their own, under current law, they can exempt a provider from the 10% provider rate cut by category. They've done that in certain cases where they've determined it will have an impact on access. So unless they do that voluntarily, the next opportunity to change that would be in the next budget round cycle, which would be in January of 2020.
Bob, I just got another question. Would there be, when it comes to patient complaints and outreach there, is there a centralized location where we can kind of funnel all of the complaints into kind of a patient hotline? Is that what you were talking about before? Is that what kind of where we funnel all that into then?
Right. There's kind of an ombudsman. It's a helpline. I'll get that posted and share it with people and put it on the website. I don't have it off the top of my head, but I know it exists.
Would it be good to like kind of look at something, because we have People for Quality Care at VGM that kind of also helps that, but is able to track that as well. Maybe looking at other sources, because sometimes when it goes to those ombudsman, it kind of disappears into the ether per se. Should we be tracking any of that?
Yeah, that's part of the resources we can provide people to help them engage their patients. Yeah.
And we can start. We'll look, folks. We'll look at that as kind of as our next board meeting gets together and our next call on the Medi-Cal task force. So we'll keep you guys updated on that.
There is a question that came in here. How will the proposed rates impact the 4th month reduction for capped rental items with Medicare? I think anything I would say to that would be pure speculation. I don't think Medi-Cal has done any reductions on rental rates after the 3rd month historically. So to guess at what they might do going forward would be speculation on my part. Does anybody have anything more concrete to answer that?
No.
Who can we contact at DHS directly?
The director is Jennifer Kent. And there are other people in the managed care division, so we can provide some of that information too.
Information for her?
Yeah, we'll put that in our information base on the website.
Because if all suppliers were to start calling DHS and saying we're not on board with this, and less than the 50% they anticipate will not be participating, what will happen at that point?
Right. No, that would be good to do.
Okay. If you could get somebody, because I know trying to get in touch with somebody at DHS is like, a treasure hunt. And if there's a direct number for Jennifer Kemp or her assistant, that would be helpful, I think, for us all to start calling Medi-Cal directly. That we cannot.
Right.
I'm in a very rural area. I cover 10,000 square miles I was almost out of business until the rural rates were put forth, and I would have had to close my doors. If this goes through, it's the same thing will happen again.
Yeah, exactly.
So, do they not realize that Medicare raised the rates for rural providers because everybody was going down the tubes? Did they not get that memo?
And I think, Craig, if you actually want to go into it, because the Cures Act came before they did rural, non-rural, correct?
That is correct. Yep. The Cures Act, so yeah, the IFR that set the rural rates came later. There were no rural versus non-rural when the Cures came through. They are not accounting for that at all in any of this. It's a great point. It's been made in several letters and emails and conversations, I think, that Bob and Dave and Paul have had with various people out there, Terry. I think that at the end of the day, what Bob said earlier sums it up best. They've heard us say, well, we can't do this before, and they just plain don't believe it until there's blood in the streets or blood on the water or whatever. They need proof that providers actually mean it, and I don't know how to best convey that, but yeah, I just don't think they take it seriously yet.
Well, and at the same time, every license and permit I have through the state of California continues to go up because they say they need more money to run their departments. How is it that they think that we can do with less every year and they need more every year? Ironic.
No argument here.
Nope.
True, and this is why they don't have to make as many surveys, because if you're okay with Medicare, they don't have to do that. But yet they keep raising the rates more. I think we pay more than any other state.
Hey, Bob, this is John Passar again. Real quick, just to let everyone know, our effort on this was significant, and I want to thank Bob Ackerman and his efforts. We do not pay Bob Ackerman a lot at CAMS as our executive director, and I know he put a lot of time and effort into this, as well as a lot of us as board members at CAMS. So I want to thank Bob for the little amount of money that he does receive for CAMS for being out there at the state and really helping support as much as we can. And I encourage everybody on the call to really, I mean, we do need more money for PR campaign and for Perry Communications and to continue on promoting our services and to gather the patient stories that are going to occur. I think there's going to be a lot of providers here. They're going to recognize their financial stress on their organizations and not accept patients. And when you do not accept patients, and you hear those patient complaints, you need to centralize those patient complaints appropriately so that way we can gather those patient stories and those issues and have VGM work together with Perry Communications in order to push that story back up to the state, and also to make sure that those patients contact their local congressman, their assembly members here that's in the state. So I think Bob, we're going to be creating an action item, a one-page action item list. I think on the CAMS, we're going to push out to all the members here. I think, and in regards to where the patient should contact, as well as some of our action items collectively. And I know we're limited, and everybody has to make their own decisions based upon their own organization, but I can tell you that if we don't take this serious and if we don't recognize the fact that we can't accept patients based upon these financial conditions, you know, it's going to be, they will not listen to us. That's the only possibility for us to overturn this is people to recognize there is going to be access to care issues based upon each individual company making their appropriate decision here. And everyone is going to have to make their own decision. We presented the financials, we presented the information. Now everyone has to make the choice, but it's going to be a choice of A, deciding whether you want to accept those patients, and B, gathering those patient stories appropriately and taking those patient stories serious and consolidating those out to VGM, which will provide you the appropriate information on how to go about doing this. So I just want to stress that on this call. Thank you.
Well, I think if there are no more questions, we've kind of gone over time a little bit. If you think of anything, the contact information for all of us folks are in the presentation. Camps will work with VGM to push out the presentation slides and to give links or access to the calculator tool. And if you think of any other questions or anything else comes up, please feel free to reach out to any of us here that were on the call today. Again, I want to thank the folks at VGM for working with camps to put the call together, and I want to thank all the providers and stakeholders that have worked, really hard to try to fight this. So we really appreciate everybody's time today.
Thank you, everyone, for coming on. Once again, any questions, please reach out to any of us. And everybody have a great afternoon, and thank you again.